Actually, this dashboard by question thing has gone.
Shantanu, no worries. We will send you in the chat, Zoom chat.
Okay.
Welcome everyone to this yet another educational activity that we are going to do today. And this is again on a subject of glaucoma, which is a subject which needs to be understood, and also the more you do webinars on them, the less they are, because of the fact that there are so many things which need to be understood in this. The title of the webinar today is it is holistic approach for medical management of glaucoma. And this is something which not only the glaucoma specialists, of course, do, but also the something that all the general ophthalmologists also should have a knowledge about, because all of us encounter patients of glaucoma. It is my honor and pleasure to introduce Dr. B. Shanta, who is going to be the chief moderator of the session. She is the director and senior consultant of glaucoma services, Shankar Nethralaya at Chennai. Then we have my co-panelist, Dr. Rajesh Sinha, treasurer of AIOS, professor at RP Center, AIMS. We have a galaxy of speakers who have a huge amount of experience in the field of glaucoma. Dr. Rajul Parekh, Director Shriji Eye Clinic and Palak Glaucoma Care Center, Mumbai. Dr. Manisha, who is the founder and medical director for Foresight Eye Center and Glaucoma Clinic, Mumbai. Dr. Murli Ariga, Director, Swami Eye Clinic, Chennai. And I would request Dr. Rajesh to introduce the other two speakers.
Along with them, we have two more speakers who are eminent in their fields in the field of glaucoma. We have Dr. Harsha Rao, who is senior consultant glaucoma services at Narayan Nethralaya, Bangalore, and we also have Dr. Vanita Pathak Ray, who is the director of Glaucoma Center Oversight, Neo Retina Eye Care Institute, Hyderabad. We welcome you all the speakers, and the chief moderator, Dr. Shanta.
And I would now hand over to Dr. Shanta for the proceedings of the webinar.
Thank you, Dr. Namrata. It's a pleasure to be part of this program. So without much ado, I think we'll go on to the presentations. The first presentation will be by Dr. Rajul Parekh, who will talk about glaucoma diagnosis, intraocular pressure, and beyond.
Good morning, everyone. Is my slide visible?
Yes, sir.
Yeah. So thanks, Dr. Shanta, for the invitation. Thanks, Dr. Namrata and Dr. Rajesh Sinha. So my going to be the first talk, basically the opening batsman, and I'll set up the meaning for the other speaker. My talk is glaucoma diagnosis beyond IOP. So, if you know the definition of glaucoma, it's a group of ocular disorders with multifactorial etiology. And by definition, they have a characteristic optic disc changes with the corresponding visual field effect, where IOP is the major contributing factor. We must remember that IOP is not the part component of glaucoma definition. And if you look the various population-based studies, various RCTs like EMGT, nearly 50% of the patients IOP were less than 21, either at the time of diagnosis or at the time of enrollment in the study. So if you go only by the IOP criteria for the diagnosis of glaucoma, then you are going to miss huge number of patients in the early stage. You may pick up in the advanced stage, because then patient will keep complaining about that they can't see. But in the earlier stage, you may miss them. So we should not go by the IOP only for the glaucoma diagnosis. So as an ophthalmologist, I'm not talking about glaucoma specialists. All of us as an ophthalmologist, it is our job to make sure that we diagnose the glaucoma, the type of glaucoma. As I said, is a multifactorial disease. There are various types and subtypes. So we diagnose the exact type of glaucoma, we plan the medical treatment, and we follow up the patients accordingly. At the same time, majority of our patients have a coexisting systemic disease, and they may be on the multiple various systemic medication which can affect the glaucoma diagnosis as well as his management plan. So we have to keep all this in account when we diagnose the glaucoma. So what we need to do is to have a comprehensive eye examination. Before we do the examination on slit lamp, we have to have a detailed history, external examination, slit lamp examination, application tonometry. When I said beyond IOP, I never meant that IOP is not the part of the examination. IOP is must. Application tonometry, gonioscopy, dilated optic disc examination, and if necessary, investigation like perimetry and imaging. Corneal thickness, I would say, is necessary when we are talking about glaucoma in every patient. So history, there are certain important factors. Basically, the steroid is used left, right, and center. Over the counter, people can buy steroid drops. So steroid use is something which we have to keep in mind. The minor history of trauma also can lead to angle recession. The systemic disease, there are some drugs which can affect the glaucoma management plans, like patient on systemic blood antihypertensive beta blocker can mask the IOP because 70% of IOP reductions can happen patient taking systemic beta blocker. Patient on blood thinner because that affect our surgical plan. The massive blood loss, severe hypertension can have one-time damage. So all these things are very important. The general examination, like patients having the long slender build, maybe marfanoid, short stubby, well marcegini, and they have a very typical ocular features and may have secondary glaucoma. So this give us a fair amount of idea that what we need to look in individual patients. Then we go to the slit lamp examination. If the patient is dilated episcleral vein, then we know that most probably patient have a increased episcleral venous pressure and may be the cause of the secondary glaucoma. On the other hand, if the sometimes patient may have forgotten to give the history, but if you have a steroid depot, then that increase the intraocular pressure is most probably because of the steroid depot. On one hand, if on the cornea, if you have classic Crooken-Bell spindle, then the cause is pigment dispersion syndrome or pigmentary glaucoma. On other hand, if the patient has KPs, then the rise in IOP may be because of the uveitis itself or the patient given steroid drops or systemic steroid for his uveitis. So the examination helps us in making the diagnosis. Pupil examination, if the acute rise, patient can have this kind of sphincter atrophy. The sphincter tear will lead to diagnosis of angle recession. If you do proper gonioscopy, basically you need to look, or moth-eaten appearance will give you idea that patient is pseudo exfoliation. So iris examination, if you do a careful examination, then you will pick up the cause that patient basically has neovascular glaucoma and not something else. This is the normal exposed vessel, but this is a new vessels. So a careful examination will guide you into a proper diagnosis. As I said at the beginning of my talk, that IOP is not the criteria we need to use for diagnosis of glaucoma, but I never mentioned, I want to reiterate, IOP is very important because at this point in time, that's the only modifiable risk factor. So we have to check applanation tonometry, and I'm very clearly saying it should be applanation tonometry. The form of non-contact tonometry or SHIOD should not be used for glaucoma management. And IOP, we also need to remember that peak IOP, the fluctuation IOP is independent risk factor, and we need to look into it. So the studies have shown that the higher the diurnal fluctuation, the higher the risk. In fact, it is 5 to 6 times more compared to patient having low fluctuation. So IOP fluctuation is independent risk factor. Now every patient do not require full diurnal or the mini diurnal curve, but what we can do in a routine practice, we check the pressure at different time of the day. So sometime we call the patient in morning, sometime in afternoon, sometime in evening, and we get a fair amount of idea of his fluctuation. We also get an idea about his long-term peak, the fluctuation. So this is how I use the IOP measurement in my clinic, and I would recommend that. When we're talking about IOP, corneal thickness goes along with it. We know that the applanation tonometry has lots of limitation, and the corneal thickness is one of them. So every patient, especially when you are diagnosing ocular hypertension or normal tension glaucoma, please check corneal thickness. Make sure cornea is normal thickness. At the same time, I would very strongly tell people that don't use nomogram to correct the IOP. That's not the right thing. Nomogram has lots of limitation. So what I would do, and I recommend people doing that, divide the corneal thickness into low, average, and thick cornea, and use that guideline in making your risk factor profile and decision plan. When it comes to Indian subcontinent, open angle glaucoma is diagnosis of exclusion. Every patient should have gonioscopy, especially when you're going to diagnose patient as glaucoma. Okay, and I recommend people doing indentation gonioscopy because you can make out very clearly what is happening on the amount of synechiae. You can make out more clearly on indentation gonioscopy. So every patient, every ophthalmologist should learn indentation gonioscopy and preferably do indentation gonioscopy in every patient, especially with diagnosed glaucoma. So this was one patient at high IOP, central anterior chamber depth was normal, but on gonioscopy, patient is a classic the bridge synechiae, which is characteristic of AR syndrome. Of course, this patient also had a detached Colbase line, which is characteristic of AR syndrome. But when you do gonioscopy, you can find the cause and the types of glaucoma which you miss otherwise if you don't do gonioscopy or if you rely on something called ASOCT. So every patient should have gonioscopy, ideally. But if you are too busy in private practice, if you don't have time for gonioscopy, then at least in all patients whose IOP is high, or one eric is less than 1/4, if they give history of trauma, if the disc is suspicious, if somebody has diagnosed glaucoma, patient has come for second opinion, uveitis, patient having diabetes, ischemic retinal diseases, they must have gonioscopy in every patient. When you dilate, look carefully the slit lamp examination again, especially the lens. You may find the cause of glaucoma, like this patient had a old glaucoma flecum. So he had a history of acute angle closure, which was missed. This is pseudo exfoliation. This is microspherophicia. So you can find the cause of his glaucoma. Now, after that, the most important examination when it comes to glaucoma is optic disc evolution, because by definition is optic disc and RNFL changes. So when you dilate the patient, you look optic disc and RNFL very carefully. Now, it's very imperative that we do more careful examination. We want to pick up glaucoma in the earlier stage and not when it comes with bipolar notch and on-face glaucoma. And if you look at various studies, it's been shown very clearly that the optic nerve at RNFL changes happens much before the visual field changes. So optic disc examination along with RNFL examination is very important. Slit lamp, 60D, 70D, 90D, contact lens use rate-free. Don't use indirect ophthalmoscope or direct ophthalmoscope for diagnosis of optic disc changes. When you do a stereo examination, the contour of rim examination is very important. You get a indirect clue from the blood vessels and color. I may not able to explain you very clearly on this is monoscopic photograph. When you do a stereo examination, these clues gives you idea about the cup and rim, the way the vessels are bending, the way vessels are coming forward, and use that clue to diagnose the differentiate cup and rim, not the color. The documentation, disc drawing, of course, if you have photographs and photography, imaging gives you a different idea. Not they are not same as disc examination, but of course it helps us in clinical practice. There were lots of changes, and I'm not going to talk all about it. But as I mentioned earlier, that we have a habit of checking only IOP for diagnosis of glaucoma. We have a habit of only doing cup disc ratio for diagnosis glaucomatous disc changes. So please don't do that, because cup disc ratio is huge variability, and the disc ratio CDR is directly in relation to the disc size. So basically around 1.2 million axon passes from the each disc. The canal varies. The disc size varies, and if the disc size varies and the number of fibers remain same, the cup size would vary. It's just a simple logic. The leftover space is cup. The peripheral fibers forms the rim. The central leftover space forms the cup. Now, if you have a small disc, then leftover space is very small, the cup is small. On other hand, if you have a huge big disc, then leftover space is big and big cup. But this is normal, physiological. So the cup disc ratio varies according to the disc size. So if you use only CDR for the diagnosis of glaucoma, you are going to miss glaucoma if the disc is small, and if you're going to overdiagnose glaucoma if the disc is large. So please refrain from that. Cup disc ratio is directly in relation to the disc size. Yes, but CDR has value if the patient has very small cup disc ratio, which increased over a period of time. There's a definite sign of glaucoma. And second, if the two disc is similar and the cup disc ratio is different, you can see here this is small cup disc ratio, this is big. Both disc is right and left is similar. So this cup disc ratio is more. Of course, this is near notch also, but this cup disc asymmetry is definitely a sign of glaucoma. So that you must remember. The rim examination is very important. The ISNT rule basically that inferior rim is thicker than superior, which is thicker than nasal, which is thicker than temporal, which is followed mostly in 85% of the patients. So just follow the ISNT rule. ISNT will give you very good idea. The basically the rim, the ISNT rule. The second is notch. You can see here this inferior, the rim is lost. This is called the notch, the localized notch. So this is the thing you look in the neuroretinal rim. The third thing is the contour. This is the normal contour. The cross-sectional area I have shown. This is the cross-sectional area which is normal. In the early glaucoma, we have a saucerization. Inferior rim is thinned out. You can see this is sloppy. This is a saucerization of disc which happens in early glaucoma. As the damage increases, you see that the saucerization, the loss has started going close to the rim, but still the notch is not found. In this stage, this patient of course has NFL loss, but this in this stage the disc patient may have field defect, may not have field defect. So this examination will give you diagnosed glaucoma in earlier stage. Then patient is definitely the fiber is lost till the edge of the disc. This is the notch. This is superior also. This is disc hemorrhage also. So the contour examination is very important. Then the disc hemorrhage. Disc hemorrhage is very specific to glaucoma. If patient doesn't have any other systemic disorder close to the brain, and they may precede the nerve fiber loss. The other circumlinear vessels, if 50% patient may have vessels, and if there is a bearing of vessel, this again is a sign of early glaucoma. You can see here, this is the circumlinear vessel, which is very tightly hugging the rim. You can see this is the bearing of the vessel. This is early glaucoma. Parapupillary atrophy, beta zone is very specific, which is close to the disc, sign of glaucoma. The RNFL, now RNFL examination, red free light you have to use, and RNFL examination again is very important. In early glaucoma, you can see this is wedge-shaped defect spanning out. As it goes away from the disc, it becomes bigger. It touches the disc. This is the wedge-shaped RNFL defect, which is specific for the glaucoma. They're usually bigger than the vessels. This is much bigger, but if it's bigger than the vessel size, then it's specific. And this is seen in the early glaucoma. As the disease progresses, the wedge-shaped defect disappears because there would be diffuse RNFL loss. But in early glaucoma, you see a wedge-shaped defect. And you see this patient has a wedge-shaped RNFL defect and is just beginning of the nasal step. So the optic disc changes are more pronounced as visual field changes, which usually happens in early glaucoma. Myopia differentiation is difficult, so you should have a very high index of suspicion in myopic disc, and myopia has relation with glaucoma, so you have to examine optic disc very carefully. There are very huge differential diagnosis. I'm not going to talk about it, but if the pallor is out of proportion, then it's most probably neurological. You can see here, this is respecting the vertical meridian. This is a neurological field defect. On the other hand, this is a congenital anomaly, morning glory. Patient may have field defect, may not have field defect, but that would be stationary. So don't diagnose this glaucoma. This is a congenital anomaly. And when you do a dilated examination, look retina also, you find out this patient had an inferior arcuate, was diagnosed glaucoma, but he didn't have glaucoma. It was a superior BRVO causing the field defect. So you find out the cause of his field defect also. So in conclusion of the disc examination, you have to look disc size, cup disc ratio. The rim examination is very important. RNFL, hemorrhage, and parapupillary atrophy. So to conclude, the history, a complete examination that include external examination, slit lamp examination, IOP, gonioscopy, dilated optic disc examination, document them properly. And once you diagnose glaucoma, counseling is important, but that Manish and Murli will talk in more detail. I'm not going to talk about it. Thank you.
Thank you, Dr. Rajul. That was a very nice summary of how to go about evaluating a glaucoma patient, how to diagnose, and how to record all your findings. So we will keep the questions to the end of the session after all the talks. So please send in your questions. The next talk will be Holistic Approach in the Medical Management of Glaucoma by Dr. Manisha.
Thank you very much for inviting and allowing me to participate. And Rajul has nicely pointed out how we have to be circumspect and look at many more things than just IOP when we are diagnosing. Are the slides visible?
Yes.
So even when you want to look at the patient of glaucoma, you have to preferably keep a holistic approach in the medical management. What do you mean by holistic? Holistic means having a wider view at everything. As we all know very well, in glaucoma management, there are many challenges which are faced day to day. First is that there are barriers to the healthcare system in all countries, not only in a relatively third world country like ours, but even in the first world. And therefore, a large chunk of glaucoma patients remain undiagnosed. Glaucoma in early stages is difficult to diagnose, especially when the IOP is normal. So just as Rajul pointed out, you have to be very careful in your examination of other factors. Once you have started the treatment, we all have experienced this in our day-to-day practice, is that a very large percentage of patients drop out from treatment. And in my opinion also, and in opinion given by many specialists, the poor awareness of the disease is the major contributory factor. So what are the considerations for having a smooth initiation of glaucoma treatment? There are three important points which we have to keep in mind. And if we take it carefully, keeping in mind these points, we can reduce the dropouts or failure in adherence and persistence. First is the choice of the therapeutic agent should have a good effectivity. So even from the early stages, it is important for us to have a good evaluation and decide the target pressure which we are going to treat, keeping in mind the age of the patients and the severity of the disease, and start early with an effective drug. Very important is the safety. The adverse reactions, not necessarily systemic adverse reactions, but local adverse reactions are very often responsible for patients dropping out. So you have to choose a drug which is well tolerated and accepted by the patient. And very important to keep convenience, because if you make the patients disturb the patient's daily life in a major way, they are not going to be able to keep up with your complicated schedule. So if you have a drug which is convenient, safe, as well as being very effective right from the beginning, the chances are that you will do well. As far as the IOP is concerned, it is not just a single thing. IOP is highly variable individually and it is dynamic. It changes throughout the day as well as over days. So you have to keep seeing the IOP at different times. And you have to see when you treat what is the change from baseline, and necessarily baseline is also a range and your treated IOP also is a range. You have to look at the 24-hour IOP fluctuations. In many cases, especially the ones who are having a normal tension glaucoma kind of appearance, and in eyes which seem to be doing progressing despite treatment, and it is difficult to do at full 24 hours. So we are all generally doing a day diurnal or an office diurnal, but in some cases you may need to do a little more investigation. You have to see the responder. If the patient is not responding to your treatment, just a minor change of around 10% or 15% from your baseline level should not be considered as a response to your treatment. You have to have a predetermined level beyond which, when you get pressure reduction, you are going to consider the patient as a responder to that treatment. And once he has responded, you have to see that the response is consistent. We have seen in many studies that the IOP response may be very good right in the beginning, but over a period of 1 month to 3 months, there is a kind of a drift, and the amount of IOP reduction is not so robust after that period. So you have to be careful when you look at these things. What to check when you are in a busy practice is very complicated, and you have to keep these points in mind. We don't know what is ideal and what is practical, has to be determined by each individual practice based on their practice profile and their systems. But you have to keep these baseline factors in mind, and therefore keep it in mind that just a single IOP recording is definitely a high risk of being misleading. So take more than one reading. Even if you are not doing a full 24 hours, it might be worth calling the patients once in the morning, once in the afternoon, once in the late evening. At least you get a gross picture. And if you start treating patients on a single IOP reading, you are likely to make mistakes in your target pressure calculations as well as your responder calculations. So it is important for you to have a range in mind. And when the entire IOP range cannot be tested, we have surrogates, but they are not always very good. So you can test, for IOP control to identify peak. There are studies which show that you can do a water drinking test to identify a peak, or sometimes do a supine IOP after making the patient lie down for half an hour. All these tests are there to identify peaks, but they are not as good as a diurnal fluctuation. So you have to choose a drug, if possible, which has a consistent effect for the 24-hour period, and that will help the patient's adherence as well as his control of the disease. The commonest cause for patients to withdraw from treatment is the adverse effects to the topical glaucoma treatment. Sometimes they are vision related, quality of life. Very important is what we sometimes fail to understand is that a dry eye is a big contributor for drop in quality of vision and could be the cause that patient is dissatisfied with his treatment and discontinues it. So it is very important the patient has a good quality of vision and that the drug is not contributing in any way. Only then it's going to be adherent. And it has shown, many studies have shown that a large number of patients, almost 46, that's almost half the patients, are withdrawing treatment because of common side effects. And therefore, side effect profile monitoring is very, very important besides just looking at the therapeutic effect of the drug. And this study has shown dropouts, and it seems that all drugs within the first 6 months, almost 30–40% seem to be discontinuing their therapy. However, the prostaglandin type of drugs are the best as far as persistence is concerned, and the alpha agonists, beta blockers, carbonic anhydrase, all of them seem to be discontinued pretty early. So reasons we can look into, but I think the main important reason people prefer prostaglandins is because of the convenient single day dose. But all is not hunky-dory and perfective as far as the prostaglandins. This hyperemia is a very, very important reason for people's dissatisfaction and discontinuation of the therapy. Almost 1/3 of the patients are complaining of hyperemia and discontinuing therapy because of it. So looking at the red eye, as we see in our day-to-day practice, there are variable grades to just a little pink eye to a little more than that. And as you can see on your right, a real horribly congested eye, which the patient cannot probably step out of his house with an eye which looks like that. So you have to keep in mind these points about how much red eye is being caused by the drug. And there are ways to mitigate the red eye too. One is to use lubricants. The second way, sometimes I prefer patients to put the drop when it is chilled by putting it in the refrigerator and putting it. That seems to reduce the red eye. But in some cases, it just doesn't work. There are other contributory factors which increase the red eye, and one of them is blepharitis and lid conditions. So we can treat those more effectively. Sometimes that helps. So keeping in mind that reducing or minimizing the red eye that the patient experiences is one very, very important step you are taking in making sure the patient continues his therapy. So the treatment provider has to keep in mind certain points. One is that the adverse events profile with or without good pressure control should be satisfactory. How much is the difficulty patient has with the medication schedule, and whether they have some physical disability of putting drops where they have to depend on other people, and arthritis and neurological diseases as well as poor vision are very important factors which contribute to patients' inability to administer the drops themselves. And in our country, cost, of course, is very important. If you have prescribed a medicine which is very effective, minimum side effects, and everything is good, but if it is expensive to the range that patient cannot afford it for a long time, I doubt he is going to continue. And one of the most important factors is disease awareness and counseling. So patients need repeated feedbacks on the type of the disease they have, what they should expect over time. And I have a very simple thing which I tell all my glaucoma patients is that you have to keep in mind that this disease is with you for a lifetime. Your spouse, your children are not going to be with you for a lifetime, but glaucoma is going to be with you for a lifetime. So you have to keep on doing what is needed to take care of it. Otherwise, it will be detrimental to you. The patient's side also, good awareness is very important, but as people grow older, they tend to forget. And forgetfulness, though a very negligible point for us, is a very important point for the patient. And keeping patients reminded about when they need to put the drops, I think cell phones are the solution, and alarms put on cell phones seem to do the trick pretty well in most cases, which I have noticed. So coming back, we have to give effective therapy and with a very low incidence or minimize the incidence of side effects and adverse reactions and keep the patient's convenience in mind. Only then we are going to get success. So it is a balance between efficacy, safety and tolerability, and patient's acceptance of the disease. Keeping in mind all this, you see the quality of IOP control, the mean reduction from baseline, the percentage of the response, and whether it is maintaining in the long term. So once you have started the treatment and evaluated shortly, what happens over long term is also very important. And keeping in mind 24-hour fluctuations is a very important point, besides patient compliance and persistence. So ideal drug for treatment would be one which is effective, giving quick IOP control and better circadian control, IOP 24-hour fluctuations, a very high responder rate, and consistent long-term pressure reducing effect. The safety and tolerability, low adverse reaction incidence, and preferably free of preservatives or optimized preservatives, so low concentrations of BAK. With this, if it is able to give stability of visual fields and improve the microcirculation, that would fit the bill ideally. What besides medication for IOP control, lifetime changes, getting good sleep is very IOP control. The meditation has been shown to be beneficial in many studies. So having calming kind of a meditation is useful. Avoiding large quantity of water intake at one time, which is known to produce very high pressure fluctuations. The general health of the patient is important, controlling comorbidities like BP and diabetes. Besides, there is a great beneficial effect in IOP control with exercise, especially the aerobic exercise rather than the resistance exercise. What is the role of supplements and vitamins? We aren't very sure, but there are some studies showing beneficial effects with vitamin B3, but it is still early days. All the same, as we have learned in the last 7 to 8 months, keeping away from vitamin deficiencies is helpful for general health and immunity. So therefore, it is also going to help for controlling degenerative diseases like glaucoma. The comorbidities which often play a role in the deterioration of patients, very important, is nocturnal hypotension. In patients who have moderate to severe glaucoma, I usually go and make a specific point to investigate the type of hypertension medicine they are taking and the timing, especially if they are taking night doses. We have to consult with their cardiologists or physicians and try to convert it to a daytime dose. Also in patients who have a tendency for low blood pressure or are showing progression despite a very good control, doing a 24-hour BP test and identifying whether they are dippers is very important. Sleep apnea seems to be getting more and more involved in all chronic diseases, so also in glaucoma. And there are studies coming out of a significant number of open angle patients who have sleep apnea as a contributory factor. In some cases, ischemic conditions may be playing a role. So small percentage of patients you need to keep in mind and do carotid and ophthalmic artery flow studies and see whether there is some contributory factor. Overall, I would say keeping the patient as a whole in mind, considering their lifestyle, age, comorbidities, and other limitations has to be given due importance when deciding the therapy for the patient. Thank you very much.
Thank you so much, Dr. Manish, for highlighting the complex nature of diagnosing and managing glaucoma. It's not just treating intraocular pressure, but a lot of complex factors have to be taken into account. So the next talk will be given by Dr. Murali Ariga on the importance and impact of long-term intraocular pressure control in patients with glaucoma.
Yeah, very good morning, and thank you, Dr. Shanta, and thank you, Dr. Namrata, Dr. Rajesh Sinha, the AIOS, and the Santon team for this opportunity to speak to you all. I'm going to speak to you about the importance and the impact of long-term IOP control in the management of glaucoma. We all know that currently our glaucoma management sometimes depends on just a single IOP measurement, or what we call as spot measurements or a snapshot measurement of the intraocular pressure measurement during clinic hours. But we also know that IOP is not just a fixed single value for a given. It's not like the height of an individual. It actually fluctuates, and it can fluctuate and vary with blinks, eye rubbing, can vary through the 24 hours called the diurnal fluctuation. It can vary in the short term over days and weeks, and of course over the long term over years and months. So sustaining a constant IOP and reducing the peaks or fluctuations may be as important as achieving a target intraocular pressure for the effective management of glaucoma. So then you may ask me as to what is this so-called normal fluctuation and what happens to normal individuals, what happens in glaucoma individuals. In the normal population, the mean intraocular pressure is said to be about, say, 14 plus or minus 2 standard deviations, and the short-term IOP fluctuation is measured to be around 4 to 6 millimeters of mercury. These IOP measurements, which are taken through the day, for a typical individual, the IOP will peak in the morning and early afternoon maybe, and actually troughs in the afternoon and at night. And there may also be some spikes of the IOP on waking up in the early mornings. Whereas in glaucoma in general is associated with higher fluctuations. So this is the picture of the so-called 24-hour IOP diurnal in normal as compared to glaucoma. You can see clearly that the fluctuation of the intraocular pressure in a 24-hour period is much higher in the glaucoma individual as compared to the normal. But the normals also, there is a fluctuation in the pressure, and there's a little slight peak at the waking time. The circadian variation in intraocular pressure, that is the variation in 24 hours for a normal individual, can be up to say 4, 5, and 6 millimeters over the day. But for a glaucoma patient, an eye with glaucoma, the fluctuation of circadian variation in 24 hours can be much higher. So what are this is one thing I just wanted to highlight, this publication and paper, which shows us what actually happens to the fluctuation in different glaucoma subtypes. In normals, as I already mentioned, it's about 4 to 6 millimeters of mercury. In glaucoma subjects, it could be about 8.3 to 2.5 plus or minus the standard deviation. And in normal tension glaucoma, the peak is mostly nocturnal, but the short-term IOP fluctuation is also slightly higher. In PSCG, the fluctuation is definitely higher. In ocular hypertension, also the fluctuation is higher than normal, but the significant and very high fluctuation or very high peaks, especially in the afternoon, can be noticed in secondary glaucomas, and the IOP fluctuations can sometimes vary between 15 to even 40 millimeters of mercury in secondary conditions like pseudoexfoliation and other conditions and so on. So keep in mind that a static snapshot of the intraocular pressure with one single reading is not enough. We need to look at IOP through the day. And as Dr. Manish pointed out, it's practically difficult to do a 24-hour perfect measurement of the diurnals in most patients. So what we do is we do a day variation to measure pressures in the morning, afternoon, and the night in different parts and different times of the week and month. So we get an idea of what the pressure is like for the patient. So one may ask, how does this actually, the fluctuation, cause damage to the patient and cause damage to what happens to the glaucoma because of this fluctuation? So the regular circadian IOP variations, the nocturnal elevation of the IOP may actually cause damage, which is undetected by the IOP level measurements during office visit. And the elevated nocturnal IOP combined with the drop in the BP that occurs during sleep may compromise the optic nerve head perfusion in susceptible individuals. In patients with glaucoma with an exaggerated nocturnal dip in the BP have been found to have a significantly high disease progression rates as well. And irregular and large IOP fluctuations, such as the normal rhythmic regular cycles of IOP peaks and troughs, are normal, and there are compensatory mechanisms which takes care of this peaks and troughs. But if this steady state of this normal fluctuation is disturbed by irregular elevations of the IOP, or if compensatory mechanisms are faulty, then the damage is more likely to occur. So some studies have clearly shown us that the relative risk of the glaucoma progressing in about 5 years when the diurnal IOP range is low is very low, as compared to the diurnal IOP range of 5 or more, the relative risk of disc progression or the disease progression within 5 years is quite high. So this is a study which I think all of us might have read in the past. This is the Advanced Glaucoma Intervention Study, which has shown that the larger long-term IOP fluctuations are associated with greater odds of visual field progression, which means that in eyes with fluctuation of more than 3 millimeters showed visual field progression, and every millimeter of IOP fluctuation increased the odds of visual field progression by 30%. So therefore, in multivariate analysis, the IOP fluctuation is an independent and strong predictor than the mean IOP for visual field progression. So keep in mind that even in the long term, this has to be kept in mind. A recent meta-analysis also showed that the long-term IOP fluctuation was a significant risk factor for visual field progression. This is not just one study like the AJS, multiple papers, multiple studies. And if you look at the overall hazard ratio, it's very clearly telling you the combined HR was 1.43, and definitely shows that the long-term IOP fluctuation is a significant risk factor. A Japanese study in NTG showed that the risk factors for progression included disc hemorrhage, long-term IOP fluctuation, and of course, a large cup dysplasia. So what then should be the ideal target fluctuation IOP, which you should keep in mind? Fluctuation in intraocular pressure is less essential in early disease, or it may take longer than the typical 5-year study period to demonstrate the effects of IOP variation in early glaucoma. So we need to look at the stage of the disease and decide is fluctuation important for that particular eye, and how soon or how late this can affect the patient. There is no widely accepted target IOP fluctuation, and I suggest that the range could be less than 5 mm for patients with mild glaucoma, less than 4 mm mercury for those with moderate glaucomas, and less than 3 for those with advanced glaucomas. There are of course many other considerations in addition to this guideline, including the corneal thickness, the rate of progression, and so many other factors which we discussed earlier. So, or how do we deal and how do we decide what to do for a particular modality of treatment as far as 24-hour IOP control is concerned? As Dr. Manish pointed out, the prostaglandins seem to be the ideal as far as uniform 24-hour IOP level control with once daily dosing, reduces the fluctuation and flattens the IOP spike that happens on waking up. Timolol doesn't do much, and it has a lower efficacy as far as intraocular pressure, has low nocturnal efficacy, and of course we all know the effect that timolol has, something called the escape, and the long-term effects of timolol. It tends to drift, and the efficacy drops over many years of usage. Carbonic anhydrase inhibitors, their nocturnal efficacy is better than timolol, but not as comparable as the prostaglandins. Brimonidine has a low nocturnal efficacy. Combinations, among the combinations, PGA, the prostaglandins with timolol seem to be better than other fixed combinations like brimonidine, timolol, CAI in timolol in reducing the mean diurnal IOP. SLT also reduces the short-term fluctuations, but essentially works like one single drug and may not be as effective as combination therapy or surgery. Surgery seems to reduce the diurnal IOP fluctuation much more effectively than anything else that we know of. So in patients who are advanced glaucoma and progressing despite everything else we do, surgery seems to be the answer. Talking about one particular drug which I have come across recently is tafluprost, which has demonstrated significant long-term IOP lowering effects across various types of glaucomas. And the mean IOP was significantly reduced in patients with all types of glaucoma over 2 years, 24-month period. Similarly, there have been studies which have shown that tafluprost may actually improve and preserve ocular blood flow. And this is shown in this particular study from Japan. How does it work? It's supposed to inhibit the ET1 mediated vasoconstriction and thereby reduce the improve the ocular perfusion as compared to latanoprost, which doesn't do so. And of course, the prostaglandin drugs like tafluprost have shown excellent long-term visual field stability as compared to latanoprost over 3 years with no significant changes in the visual field and associated with stable visual fields in a significant number of patients. So to cut my story short, a take-home message: despite conflicting research results, IOP variation does seem to be important in the evaluation and management of patients with glaucoma. Not only is an ideal mean target IOP needed, but we also need to consider a target for IOP fluctuation. And clinicians have to be cognizant of this risk factor, maximize the strategy to detect the fluctuation, and tailor the treatment, particularly in vulnerable patients who show progression despite achieving target intraocular pressure. Thank you all.
Thank you, Dr. Murali. So that was a very clear indication of how complex IOP management is and what are all the factors involved in a long-term management of a patient who will usually be with us for at least 20 to 30 years. So although the prostaglandins have really given us a wonderful treatment strategy for glaucoma, they are associated with side effects. And Dr. Harsha Rao will take us to what are the side effects which have been recently discussed about, and is there any way of managing them?
Thank you, ma'am. I hope I'm audible and the slides are visible.
Yes, please go ahead.
Thank you, ma'am. So I thank AIOS Santen for this invitation, and also for a topic which is very rarely spoken about. So we will try to understand why that is so and what all we know about this side effect of the prostaglandins. So this is prostaglandin associated periorbitopathy, which is called PAP. These are my financial disclosures, nothing particular to the topic which I'm talking now. So in this talk, we will briefly discuss about the definitions and the mechanism of PAP, the incidence and prevalence of PAP, the impact of PAP on glaucoma management, how do we manage it, and the summary of it. So PAP is probably one of the most recently defined side effect of prostaglandins. So it was in 2004 that Paplinski and Smith came out with the first report of deepening of the upper eyelid sulcus with topical bimatoprost therapy. And I think that's from when a lot of people started recognizing this side effect. So if you look at the couple of examples which they had mentioned, I will probably take you through the second example here. Here is the patient who was started on bimatoprost therapy in the left eye, and this arrow points towards the deepening of the upper eyelid sulcus here in this eye, which is very conspicuous when compared to the other eye. The patient was subsequently challenged with bimatoprost to her right eye. That's when the right eye also started showing the deepening of the upper eyelid sulcus. And then subsequently, when bimatoprost was discontinued, this deepening regressed. Subsequently, as I said, a lot of people started noticing these side effects. And in addition to this, this deepening of upper eyelid sulcus is commonly called as dews. In addition to this, there were certain other changes seen in the eyelids and around the eye in patients on long-term prostaglandin analogs. And together, all these signs were put under the definition of PAP. So essentially, the definition of PAP is all that side effects of PGS that occur around the eyelids. And these are the 7 signs of PAP. One is the upper eyelid ptosis. Second is the dews. Third one is the involution of the dermatochalasis. Dermatochalasis is the excessive skin in the eyelid, and the involution of this is seen with prostaglandin analog use. Orbital fat atrophy, mild enophthalmos, flattening of the lower eyelid bags called phlebs, and inferior scleral show on a tight orbit. Here is an figure which shows most of these signs. See, this patient is on prostaglandin analog to the left eye, and we can see the mild upper lid ptosis here, deepening of the upper eyelid sulcus, involution of the dermatochalasis. If you look at the right normal eye, which has this excessive skin here, that's absent on the treated eye. Orbital fat atrophy, which also gives an impression of mild enophthalmos. Flattening of the lower eyelid bags. This is the flattening seen in the lower eyelid here compared to the normal eye. And then the inferior scleral show on a tight orbit. What's the mechanism of PAP? So the mechanism of PAP essentially is anti-adipogenic effect of prostaglandin analogs. So PGAs inhibit adipogenesis and cause adipocyte atrophy, and that's now established as the primary reason for PAP. There are multiple other basic science experiments which have once again showed this mechanism. Here in an interesting study, the transcription factors which were responsible for adipogenesis were studied, and the effect of multiple prostaglandin analogs on these expression of transcription factors were analyzed. And what was found was that bimatoprost and travoprost reduce the expression levels of these adipogenic transcription factors. So the control bar is here, and the reduction in the transcription factors with travoprost and bimatoprost is shown here, which is found to be very significant compared to latanoprost. If you can look at this graph, we will discuss that subsequently. The other way of looking at the anti-adipogenic effect of prostaglandin analogs is to look at the differentiation of pre-adipocytes to mature adipocytes. The mature adipocytes take up oil redwo staining very well. Here is the control, which is taken up oil redwo staining, which stains the intracellular lipids. So in the differentiation stage of this pre-adipocytes, if they are treated with prostaglandin analogs, you see very, very less number of mature adipocytes, be it latanoprost, travoprost, or bimatoprost, even tafloprost here. But uniprostone showed very little effect on the adipogenesis, for that matter. So what's the onset and prevalence of PAP? So most of these studies on PAP are from Japan, for that matter. PAP has been studied extensively in Japanese patients, not to that extent in other patients. This was an interesting study where the incidence of PAP was compared in patients on multiple prostaglandin analogs, and what they found was in glaucoma patients who used bimatoprost, close to 60% of these patients showed signs of PAP, or DUEs for that matter. 50% of those on travoprost showed the presence of DUEs, while the number of patients on latoprost and tafloprost showing this side effect was much lesser, as well as uniprostol. So also there are other couple of studies which showed that shows the regression of PAP when the patients were shifted from bimatoprost to latoprost. So in this interesting study who had presence of PAP and were on bimatoprost, they were shifted to when they were shifted from latoprost to bimatoprost, close to 60% of them showed DUEs. So which essentially tells the fact that the occurrence of PAP is more common with bimatoprost compared to latoprost. In addition to Japanese patients, there's one more study from Turkey, which also looked at the onset and prevalence of PAP in their patients on bimatoprost, latoprost, and travoprost. And what they found was the incidence of PAP was very high, once again, in those using bimatoprost. So 93% of patients on bimatoprost showed some of the signs of PAP, while only 40% of those on latanoprost showed signs of PAP, while those on travoprost showing the signs of PAP were 70%. So that was between latoprost and bimatoprost. Also, the study found that the presence of severe PAP essentially referred to DUEs, while mild PAP referred to the fat atrophy, things like that. So it was severe PAP, once again, was more common with bimatoprost compared to latanoprost and travoprost. The first sign which was noticed, the first PAP sign which was noticed was in fact periorbital fat loss. Very interestingly, this is the only Indian study which I could come across, longitudinal Indian study, which looked at the prospective study, which looked at the incidence of PAP in Indian patients. So this study followed the patient for 6 months and evaluated the occurrence of PAP. And what they found was that there was a small study with 32 patients, 63 eyes. If you look at the initial visit here, it was only 6% or 4 eyes. 6% of the eyes had signs of DUEs, while over the follow-up period of 6 months, 35% of the eyes showed signs of DUEs. So all these studies also show the fact that PAP or DUEs or any of the signs of PAP generally occurs anywhere between 4 to 6 weeks from the onset from the time of starting the prostaglandin analogs, and they can manifest anywhere up to 6 to 9 months after starting the prostaglandin analogs. That's the general onset period of PAP. Now, what's the impact of PAP on glaucoma management? One is the cosmetic influence of this. This can affect patients' social life, confidence, quality of life, especially if the prostaglandin analog is prescribed to one eye. This in the long term can affect the adherence as well. The other one is the pseudoorbital pathology, which is associated with it, which may require some management as well if the patient is concerned. But what's more important from the glaucoma management point of view is the effect of PAP on the intraocular measurement and the effect of PAP on the surgical outcomes. IOP measurement, the tight orbit, tight lids themselves can cause a problem in the precise intraocular measurement. This was once again a very interesting study which compared the intraocular pressure measurements with GAT and eye care in those with tight orbits due to prostaglandin analog use. It had a control group of 70 subjects, where the difference between GAT and eye care measurements for the intraocular pressure was 1.3 millimeters of mercury. So essentially, eye care measured the intraocular pressure 1.3 millimeters of mercury on an average, less than that measured with GAT. But in the group with tight orbit syndrome, the intraocular pressure measured by eye care was on an average 8.6 millimeters lesser than that measured with GAT. So what this indirectly tells is that the GAT possibly overestimates the intraocular pressure in eyes with tight orbits or tight lids for that matter. So this can affect the measurement of intraocular pressure and the decision subsequently. How does PAP affect the outcomes of glaucoma surgeries? We all agree that we have seen patients with tight eyelids when we are trying to take their intraocular pressure measurements, when we are trying to manipulate the globe during the surgeries, or when we are trying to manipulate the globe for laser suturalization. So, but does this affect the outcome of the surgeries too? Once again, a very recent study showed that the probability of failure, which essentially is defined as the increase in intraocular pressure after the glaucoma surgery, the trabeculectomy here. So the probability of failure or increase in intraocular pressure was much higher in eyes which had DUEs before the surgery. So what it essentially meant is that the presence of PAP can adversely affect the outcome of trabeculectomy. There's a small retrospective study, and longer studies would definitely throw more light on this. So how do we manage PAP? The simplest is to shift the patients to other class of anti-glaucoma medications which don't cause this side effect. However, then we are denying the patients of the other benefits of a prostaglandin analog in that case. The other method is to shift them to the other prostaglandin analog. Here are a couple of studies which shifted the patients either on travoprost or bravoprost or bimetoprost who showed signs of PAP to latanoprost, and a lot of these patients showed recovery of the PAP signs. So here are the examples. Here is the patient who has DUEs, both eyes. This is after shifting the patient from travoprost to latanoprost. DUEs much better, and at 6 months, we hardly see any signs of DUEs here. Another patient with unilateral DUEs subsequently improving after shifting from travoprost to latanoprost. So another study quantitatively showed the effect of shifting from bimetoprost to latanoprost on the symptoms of DUEs, and what it showed was close to 85% of the patients who were shifted from bimetoprost to latanoprost, who earlier had signs of dues showed improvement. So this is negative dues after shifting the patients from bimatoprost to latanoprost. So a significant percentage of patients, when they are shifted from either bimatoprost or travoprost to latanoprost, show improvement in their signs of PAP. So the other way of managing patients with PAP is to shift them to a novel class of medicines called EP2 agonists. So the commonly used prostaglandin analogs are FP2 alpha agonists, but a new class of EP2 agonists have very little effect on the adipogenesis and therefore have no or very little PAP occurrence. One of the commercially available EP2 agonist is called the OMD, or the omidinipag isopropyl. Ibelis is its commercial name. It's marketed already in Japan. So this, once again, is a basic science experiment which showed very little effect of EP2 agonists on the differentiation of pre-adipocytes to mature adipocytes. Here is the undifferentiated adipocytes and the differentiated adipocytes taking up oil redose staining very well. When treated with latanoprost or prostaglandin F2 alpha, they don't mature into adipocytes, while those treated on omidinipag, which is the EP2 agonist, showed good uptake of oil redose staining, which essentially tells that EP2 agonists have no effect on the differentiation of adipocytes. There are clinical small case series which also show that when patients with signs of PAP and on latanoprost or travoprost or bimatoprost were shifted to the EP2 agonist, a good number of patients showed improvements in the signs of PAP. So in summary, PAP in Indian context definitely is an under-recognized and under-reported condition. We need to understand that it can affect the patient care in many ways. It's important to be mindful of its occurrence and probably carefully look for it in all our patients. Thank you.
Thank you, Dr. Harsha. So the last talk will be given by Dr. Vinita, who will talk about her experience with tafloprost, which has been available in the Indian market for the past 1.5 years. All of us have used it, and we would like to know more about what the Indian experience is.
Thank you very much, Dr. Shanta. I request Harsha to unshare his screen, please. Harsha, are you with us? Yeah, thank you. Right. Whilst all the talks preceding mine have made my job very easy, and I do thank AIOS and Santon to help me present my experience with tafloprost in India. I do have a few disclosures, including Santon. So whenever we talk about a prostaglandin analog, one of the very pertinent questions is, do we really need another one? Now, this one has a back concentration, or the preservative concentration, which is much lower than of other commercially available back preserved anti-glaucoma medications. Plus, on top of that, you have a non-preserved one as well. So let's see whether that has made any difference. As with any PG analog, the efficacy of the drug depends on the outflow mechanism, and this, like all other PG analogs, is through the non-conventional channel. Now, desirable characteristics of any anti-glaucoma medication is, of course, its efficacy as well as its safety and tolerability, as alluded by several speakers before. Not only to reduce IOP in the short term compared to the current gold standards, or but also long-term IOP, 24-hour IOP, and preservation of visual fields. Also desirable is that it is effective in all etiologies of glaucoma and effective when administered not only in treatment naive eyes, but also when you are switching it and as an add-on therapy. And they should be gentle to the ocular surface without any serious side effects and definitely no systemic side effects. So when we balance both efficacy and safety and tolerability, that's when we can ensure both persistence and adherence with therapy. So just a brief idea about tafluprost. It received FDA approval in 2012. There were other players in the market then. It was based on several controlled clinical trials. I will mention two. One is a 24-month phase 3 clinical trial of 500 and more patients, which established, comparing it with latanoprost, it established non-inferiority of tafluprost when you compare it with latanoprost, and also rate of hyperemia and other ocular surface symptoms was much less compared to latanoprost. Another study, which was randomized double masked 12-week tafluprost versus timolol, this too showed that greater than equal to 25% reduction was achieved by 60% at 12 weeks. And again, rates of conjunctival hyperemia only about less than 5%. So a very acceptable safety profile. Now, tafluprost, there are several studies which have shown that tafluprost provides effective 24-hour control. In this particular study, you can see compared to baseline here in the blue graph, the tafluprost has done well throughout the diurnal period, including nictor hemorrhage. At all time points, significantly reduced. This was alluded to before by Dr. Murli Ariga. Even long-term control in several etiologies of glaucoma, it has been found to be significantly reducing IOP at all time points. And what is more important is that survival in terms of persistence and adherence was almost 85% at 1 year and 76% at 2 years, which is pretty good. And adverse reactions were 18.64%, but most of them were not, they were self-limiting, should I say. And this was a study that was conducted after marketing, post-marketing survey. When compared to other prostaglandin analogs, travoprost as well as latanoprost, it was found to be effective. This study was done again in Japan in 90 NTG patients, and you can see the effect. And when it was administered not only in treatment naive eyes, but also when they were switched and when it was given as add-on therapies, it significantly reduced intraocular pressure. So what about safety and tolerability? We all know these kind of eyes means there is a dip in persistence and adherence. But when a study was done, when photographs were taken after administration of the 4 different types of prostaglandin analogs, and it was binary. The photographs were binarized, and they were then measured by an automated hyperemia analysis software. It was found that tafluprost had the least amount of hyperemia. Other than this, I can show you photographs now of real-world photographs of my patients. You can see both eyes are red, but left one is more than the right one. This is actually post-surgery, 1 week post-surgery. Patient has done much better, but you can see this is a JOAG patient in early 40s. You can see the changes, orbitopathy, as been alluded by Dr. Harsha. Yet another patient, even younger than the other one. This patient is only 32 years old. Now, his eyes are not red, but look at the amount of tightness of the lower lids, the cicatricial changes that are associated with this orbitopathy. And what takes the cake is this. It really breaks my heart seeing this 23-year-old, very smart young management student who first came to me with PDS. She had very advanced glaucoma in the left eye. That surgery was done almost immediately, I would say within 3 months, yet look at the changes in her orbit. Unfortunately, the right eye continues, or at the time this photograph was taken, she was still on anti-glaucoma medications. Since then, of course, she's had trabeculectomy. And when a study of DEWS was done, but this has also been alluded to, I will not stick to it, and our very own example in an Indian eye. So I will present to you my experience of tafluprost in a limited number of patients. Please remember that this was introduced in India only in August last year, launched, both Rajul and I were there, fortunate enough to be there. And because of the COVID situation and the lockdown period, a lot of follow-up has been very erratic. So I don't like to present anything which is less than 6 months. So I currently only have 26 eyes, more than six or more than 6 months follow-up, of which 10 are treatment naive. Follow-up is almost 9 months, and switch or 16 eyes follow-up is close to that. Etiology, a majority were primary open-angle glaucoma or its variants like NTG, OHD, and JOAG, and there were a few primary angle closure glaucoma eyes as well. So in the treatment naive group, the pre-IOP maximum was 23 and the post-IOP was 15.8. So I achieved a decrease of 34% at about 3 months, and this was sustained at last follow-up to about 31%. This decrease was statistically significant. And there was not a single patient who did not report comfort with the eye drops. When it was switched, and again, follow-up being more than equal to or more than 6 months, there were 16 eyes, 8 were on other prostaglandin analogs, some were on fixed combinations, and the reasons for switch were inadequate IOP control or red irritable eyes, or a combination of both. And in some, I wanted to change to a single agent, making the treatment regime simpler for the patient in accordance with quality of life. So here we are, these 16 eyes, pre-saflutan IOP, meaning patient could have been on other drugs, other prostaglandin analogs, was 19.1, and post-saflutan IOP, when all other drugs were stopped, was 15.4. So this was obviously significant, but what is more important is that additionally another 20% reduction was found. We have to see this in context. It's a very small sample size, but I'd like to take you through a couple of cases as well, which tells me about the representative cases that I have actually managed in the real world. This is a 50-year-old male. He underwent clear lens extraction elsewhere 2 years ago for very high myopia, and he was 20/20 in each eye, yet he complained of deteriorating vision. His intraocular pressure, as noted elsewhere, was 18 and 17 on a prostaglandin analog on which he had hyperemia and irritation. His CCT was average and his gonioscopy was open. And as you can see, a very, very cupped, shallow cupping, which I think probably got missed. As you can see, in February 2019, visual fields, especially in the left eye, were a lot better with VI5 of 78%. Not so much in the right eye, but central visual fields really, really advanced damage. However, the patient only came to me in October 2019, where I was very, very surprised at the change in the visual fields in both eyes, especially the left eye. So here we are, much more advanced. What I did for the patient, because the Tmax as documented, I'm not sure whether it is normal, where it was documented with NCT or not, but it wasn't mentioned, but it was 19 and 21 and the patient was 18/70. So I definitely wanted a pressure much lower than that, because the reduction I have got is not significant here, or the reduction that was achieved was not significant. So what I did was I switched to saflutan, and I got a pressure over the next year whenever I could get a follow-up of 14 to 15. not much fluctuation, which is what we want. And what is most important is that in this 1 year, he has not deteriorated any further and continues to remain the same as when he presented in October 2019. So he was stable at 1 year. Another case, this time now a 75-year-old pseudophakic general surgeon whose son actually is an ophthalmologist. He told me that he had sulfur allergy amongst others, and he had red eyes whilst reading. So initially he was diagnosed as conjunctivitis, and he was given antibiotics and lubricants, not by me, by his son. And he complained of increased redness and watering and difficulty in reading. Subsequently, he was diagnosed as glaucoma with Tmax of 22 and 32, and the CCT was average. He was given Simbrinza before he came to me, and these are his visual fields. As you can see, the left eye much worse than the right, with fixation, with changes very close to fixation, or just about involving fixation. So on presentation to me, his vision was 2030 and 2040, and his pressures were 19 and 21 on Simbrinza, on fixed drug combination of CAI and alpha adrenergic. I don't have photographs then. He was so uncomfortable, I could not document it, but this is my clinical notes. And as you can see, he had an inferior notch in the right eye, and he had a bipolar change in the left eye, and very small discs, that too. I wasn't sure whether this is open angle, primary open angle glaucoma or pseudophakic. That didn't matter. But what mattered is why was he getting so much redness and irritation with the drugs that he was on, and I questioned back allergy. So I discontinued everything and I put him on Saflotan S. For those who are not familiar with the Unim's preparation, I'd just like to show you. It comes in a package like this. It has to be refrigerated, of course, and it comes in packs of 10. 3 packs, so you have for a full month, and then you have to detach each Unims, open it up, and apply the drops in each eye. This is not the same patient, don't worry. And of course, discard after. Once it is opened, it has to be discarded after that. So here, have a look at this patient. He first came. The next time that he came was 1 week later, and his pressures were 12 and 15. Remember, it was 19 and 21 before that. So obviously, my diagnosis was back allergy, because on Saflotan S alone, he was improved almost 70% within a week. Followed by, this is his picture at the same time. And then when he was seen about a month later, just before the lockdown, actually, you can see that his eyes are much less red. He, of course, have floppy eyelids and so on and so forth, but he was much better. And at his last follow-up, his intraocular pressure was 11 and 15. I could sort out his problems of increased redness and watering, but unfortunately, difficulty in reading was because of his visual field defect, and that, as we all know, is permanent and cannot be reversed. So, where tafluprost is concerned, there is definite IOP lowering efficacy over 24 hours as well, which is similar to other gold standard right now. There is some evidence that there is superior safety and tolerability compared to other prostaglandin analogs, and that the preservative-free Saflotan S is a very important medication in your armamentarium, where ocular surface disease is concerned, as well as where back allergy is concerned. And hopefully, with all these above factors, patients should remain persistent and adherent with their therapy. And of course, where Indian experience is concerned, we have to keep following up our patients. Thank you very much for a patient listening.
Thank you so much, Dr. Vanitha. I think we'll go on to the question and answer session now. There haven't been too many questions from the audience, but some of them are quite relevant to our talks. So the first one goes to Dr. Rajul. This is a question on diurnal intraocular pressure measurement. When is it indicated, and how exactly would you do it?
So I don't do diurnal variation 24 hours routinely. It's cumbersome and is not required for the diagnosis of glaucoma most of the time. So and to do is very difficult because you have to admit the patient at night time and check the pressure. If you have institute, like when I was in LU Prasad, we were doing in lots of patients. I think still they are doing it. But I routinely do diurnal variation if the patient is progressing with the normal acceptable IOP, that is the target pressure I have decided, progressing, and I can't find any other reason of IOP fluctuation in the daytime. So I do multiple pressure checking in the daytime, their normal acceptable range, and still the disease is progressing. Those patients I would admit at the night time and check the pressure. In the rare cases, normal tension glaucoma, if I want to check nighttime pressure because 50% of the patients can have IOP spike at nighttime. So rarely for those patients. Otherwise, I don't do diurnal variation. But I would recommend that they can check the pressure daytime. So you call the patient by 8 o'clock, 9 o'clock morning, earliest possible, and 6, 7, 8, whatever time you're practicing. So you can finish the daytime curve, mini curve, and you can check 4, 5 pressures. That would really be helpful in majority of the patients.
So which instrument would you use for the IOP measurements late in the evening and night? Would it be GAT or?
No, Perkins. I have Perkins with me. So Perkins, of course, is approximately 2 millimeters less than Goldman, but I use Perkins, and I'm quite comfortable with Perkins because the eye care is good otherwise, but eye care measures little more pressure than Goldman. So I use Perkins tonometer.
So would you emphasize that it would be better if the same person checks all the IOP measurements with the same instrument?
Better. Difficult sometime in practice, but since I check nighttime pressure myself and with the only one Perkins tonometer, so it's better to check with the same machine, same person, because then the inter observer variability, inter machine variability is taken care of.
So do you think water drinking test can replace the diurnal or nocturnal?
No, I don't think so, because it's not physiological. There are lots of studies, of course, but if you look the studies, they talk about the correlation, but they're not the same thing. You are giving 1 liter water and artificially increasing the pressure. It's basically you are checking the stress and the trabecular mesh, which is helpful in lots of patients, but I don't think it can replace the diurnal curve in all the patients.
That has been our experience as well. We did a prospective study and found that there was no correlation with the mean IOP measurements and with the peak in the water drinking test. The next few questions can be directed to everybody. But I would like Dr. Manish to take the first question. So which drug would you use for normal tension glaucoma and why?
Generally, normal tension glaucoma, prefer to use a prostaglandin analog as my first choice. So because prostaglandin analogs are able to reduce the intraocular pressure to the level of the episcleral venous pressure as compared to timolol, which has been shown to have some effect on the vascularity as well as poor response in the night. And the alpha-2 agonists also are not very responsive in the night and a lot of allergy issues. So my first choice for the required amount of pressure drop in normal tension glaucoma is generally a prostaglandin analog.
This is a question to all the panelists. Is there any particular medication you would avoid in normal tension glaucoma?
I would probably avoid. Can I take that?
Please.
Yeah, sure, anybody.
Yeah, this normal tension glaucoma, as we all know, is the pressures being in normal range and possibly associated with a nocturnal dip in the blood pressure and so on. So generally, drugs like beta blockers should be avoided. Prostaglandin, as Dr. Manish pointed out, my choice also would be a prostaglandin for so-called normal tension glaucomas, as well as to avoid a beta blocker as much as possible. And also, if a patient is on a systemic beta blocker, probably discuss with the physician and discuss options for treating the blood pressure in a more in an optimum way, and stop the beta blocker if possible.
Especially if the patient is taking beta blocker at night time.
Agreed. If the patient is on antihypertensives, would you advocate any change or any change in the regimen or any change in the dosage if the patient is progressing?
Yeah, generally, actually, we have a good physician rapport, and I work in a general hospital as well. So what happens is most often we try to get a 24-hour BP monitoring, ambulatory BP monitoring for some patients whom we feel this happens. And we do find to our surprise that there are a lot of nocturnal dippers, as we call them. So this we can pick up, and we try to be less aggressive with BP control than before, and tell the physician also not to lower the BP very aggressively, and keep a watch on like how we would like an ideal 24-hour IOP control. We like to have a 24-hour BP measurement as well.
Okay, this question is directed to Dr. Rajul. If you take BP measurements, is there any direct correlation between the fluctuations in blood pressure measurements and intraocular pressure?
So if you look the population-based studies like Beverdem and others, they have reported correlation, but it's too small, to consider significant in clinical practice. What I remember, I think the Beverdem showed that for every 10 millimeter mercury increase, I think the IOP increases by 0.2, and every 10 millimeter of the diastolic increase, I think is 0.4 or 0.5. So everything is less than 1 millimeter. Not significant, but yes, if the patient is a severe acute drastic drop hypertension, those crises, the hypertensive crisis can have impact on the optic disc and can have one-time damage, which can worsen the glaucomatous damage one time, or can have one-time damage, may not be related to glaucoma if the patient doesn't have glaucoma. But in routine practice, the small fluctuation in systemic hypertension does not have much impact on IOP.
Thank you. So this another question from the audience is, do we need to have a reproducible visual field defect before we start treatment in patients suspected to have glaucoma? So Dr. Manish, could you take this question, and I'll take input from the others as well?
Basically, you have to, the treatment initiation is based on your estimation of the risk of vision loss in a short time. So to get a reproducible visual field defect, you might have to do visual fields up to 3 times. And in a patient who has hardly any visual field defect, or maybe just a nasal step or something like that, with normal pressure, I would not probably initiate treatment immediately. But if the visual field defect is close to fixation, is dense, and the pressures are high, I would not wait. And especially if it is very well correlating to the optic disc and nerve fiber layer, what you have examined or imaged, then I would not probably wait to have a reproducible visual field defect and be very strict with the criteria and initiate treatment even before. In suspect cases, yes, definitely we would wait for a reproducible visual field defect.
So this is a question to the other panelists. Supposing you have a patient with documented disc and RNFL progression, but the visual fields with SAP absolutely normal, so-called preperimetric glaucoma, would you treat, or what would you do? Dr. Murli?
I think the question you're asking is regards to progression or worsening on disc evaluation and OCT, but not on fields.
Not on fields, yes.
Okay, so I think it depends on the stage of the disease. Suppose early on in the disease, you will find that different tests will give you different sort of estimates of progression. So for early disease, you can probably use the fields and the OCT, but for advanced disease, you probably would use less of the OCT and more of the fields. So it's actually a difficult question to answer. Suppose you didn't have worsening on the fields, but you have distinct evidence of worsening on clinical appearance as well as on the OCT, you can consider definitely the patient is progressing and step up the treatment.
Well, sorry, the question was on preperimetric glaucoma.
That's right.
And yeah, so not on advanced disease. So preperimetric glaucoma also, if the pressures are not very high, I discuss with my patients. I actually tell them that possibly it is inevitable that you need to start. You need to be started on treatment. If you, as long as you don't have any functional change, and as long as you come for follow-ups, we can delay the inevitable. So some patients are very comfortable with that idea. Some patients are not. So that's how I look at it.
I think the bottom line is basically, it's a risk profile.
Yeah,
so,
true.
Depending upon individual patient's risk profile. So the baseline IOP, the family history. So if you have a pressure of 25, absolutely normal field and early disc changes with corneal thickness of 600 as versus 500 would make difference in your clinical decision. If the patient has family history of glaucoma blindness, definitely will start treatment. So I think basically, rather than saying that you will not treat or treat pre-perimetric glaucoma, I think what I would suggest that, make a risk profile of the individual patient, then discuss with the patient, because sometimes the patient, even with 20 to 23, I don't want to treat them, but they have seen the neighbor even becoming blind because of glaucoma, and they have such a severe psychological stress that in a rare cases, not in principle in every patient, but you may start a molecule which is going to reduce only 15-20%. But so basically, I would say that no, consider the risk profile, and based on that, discuss with individual patient. And there is nothing hard and fast for as a general blanket formula.
I agree. I totally agree that risk profile is very important. We are presupposing that we don't have a very significant risk profile, and then in those cases, definitely we can discuss with our patients. Yeah.
Talking of pre-perimetric glaucoma itself, I think we are talking about a field test which is probably not picking up the changes early enough as compared to the OCT technology and so on. So I think people may be aware that we now have tests like the 24-2C, which actually is a slightly different testing pattern as compared to the older 24-2, which can actually pick up the field tests in the so-called earlier pre-perimetric glaucoma. That is one. And suppose you strongly feel that you've seen an RNF field defect, you see it on the OCT, but you don't see it on a standard perimetry, you can probably even do a 10-2 field in that situation and then see the field effect where there was none in the earlier 24-2.
So Dr. Harsha, how often do you see the periorbitity in your practice? And once you change the treatment, how long does it take for the patient to reverse? Do patients complain about it, or is something you pick up on your examination?
So I should honestly confess that this is not
The signal has gone off from there.
Can I answer that?
Yeah, Dr.
Sure. Yeah, I will say that
our patients.
Sorry, he's back.
Okay, I'm sorry. So it's in the small subset of patients on whom you put the prostaglandin uniocularly that you are more concerned about it. Patients generally don't complain about it, though a lot of studies have shown that more than 50 to 60% of the patients on prostaglandin analogs develop these orbitopathies. It's not something which demands any management. Having said that, the orbitopathy improves within 4 to 6 weeks of stopping or changing the prostaglandin analogs. So in most of the cases, it is reversible. But we still, unfortunately, don't know entirely about this condition and the reversal of this condition. But if you pick it up early, 6 weeks to 3 months is a good amount of time for it to regress to a great extent.
Actually, I think we're quite fortunate in our patient profile because most of our patients are not really worried about the cosmetic nature of the disease. And if it's a really effective medication, they're happy to continue. Apparently, in places like Korea, they're very, very aware of these side effects, and they don't like having PG analogs as a primary therapy, which is very unfortunate. So we are fortunate that our patients understand the nature of the disease and are accepting of these non-threatening side effects. Though, of course, when they come to surgery, it is a bit of a problem for us. Regarding escalation of medical treatment, if you take a PG analog that you're starting with, how do you escalate the treatment? Do you, if you add on timolol, for example, how do you prescribe it? Dr. Manish?
As we know very well, timolol can be prescribed as a once a day and seems to be equally effective as twice a day if you give it in the morning. So usually I like to give a fixed drug combination. First and foremost is before you go for a fixed drug combination, I give the drug as a separate bottle for a short period to evaluate whether it is additive or not. If it is additive and is achieving the result that I would be happy with, then the next time I try to combine it in one bottle and give it as a fixed drug combination to be put in the morning. Now, every patient is not happy putting drops in the morning. And I have at least 20% of patients who very clearly tell me that they tend to forget the drops in the morning and are much happier to put the drops in the night. In this scenario, sometimes I do allow them to use the drops in the night, knowing fully well that the timolol is not going to be effective in the night period, but probably help in blunting the morning peak, which is also a beneficial effect of timolol. So usually when you want to escalate the therapy, one thing which we can keep in mind is that there is some evidence to show us that there is a little difference in the response rate between the prostaglandins, and maybe bimatoprost does give a little more pressure reduction than the others. So in a case where I probably don't have a choice, or a patient is not willing to, can't give the timolol, I would like to see if he can respond better to bimatoprost if he is already on any other prostaglandin analog. So it does make sense sometimes to shift from one prostaglandin analog to another also before you actually go in for another group of drugs.
Would you consider giving the PG analog at night and the beta blocker in the morning?
Yes, that also is suitable if the patient is happy to put the morning, but a lot of patients are missing drops in the morning. That is the problem.
Because we know that the peak effect of the PG analog is about 6 to 8 hours away. And if you have peaks in the early morning, then you would want a drug which is effective at that time. So, which is why I was asking about this.
Yeah, so that is a consideration you can have, but however, there is no uniformly followed principle or practice, even in the individual practice. So I may not advise every patient the same thing. Okay. Yeah, you have to individualize it quite a bit.
Can I just make a comment, please? Tying in the question that was put to Harsha and also what Dr. Manish answered just now, there was a spate of, orbitopathy that I saw when Lumigan 0.03 was being used quite regularly until 0.01 came into the market. But at that time, it was, I think, marketed very aggressively as the prostaglandin analog that brought down the intraocular pressure the most. So for a 1%, 1 to 2% further drop, I think it was being used much more. And now, because we are seeing so much more orbitopathy, I feel I see a lot more orbitopathy than I ever did before. And most of them have been on bimatoprost, whatever the brand. So what is important is that we have the choice of more prostaglandin analogs. Either you fall back on latanoprost, or you can even try the new ones, the travoprost or the change in the. Where doing once daily or using prostaglandin at night and timolol in the morning is concerned, again, what I have found is the moment, they go from one bottle to 2 bottles, they have been very comfortable with 1 bottle. What happens is they tend to miss, which is what he's alluded to. And so perhaps it's better to give it as a fixed drug combination rather than splitting it. I have seen many patients come to me who are on a fixed drug prostaglandin analog with a beta blocker at night and a timolol long acting in the morning. Now, here in these cases, especially if the patients are older and they have systemic risk factors, we are overloading them with beta blockers. So we have to be very careful how we actually prescribe, and definitely it has to be tailor-made for every patient. In busy practices, everyone says difficult to, but we have to, if we are to save, maintain their visual fields, we have to make the effort.
That's interesting. Dr. Harsha, in your search of the literature, did you find any difference between 0.03% and 0.01% being published? I know it's a personal experience, clinical experience, but I don't remember reading any published literature. on the side effects?
No, ma'am. I couldn't. So I didn't do a detailed search of it, but I did not find any difference in orbitopathy, for that matter, between 0.03% and 0.01%.
Exactly. Most of it talks about efficacy with lesser side effects. And I do remember some literature being passed on to me at the time, but I couldn't quote it offhand just now.
So I think all of us have come across patients in whom escalation of medical treatment has been done, and they have been put on more than 2 or 3 medications. So what is your individual interpretation of what maximum medical treatment is? Dr. Murali?
I think I'm a little more aggressive as far as surgery is concerned. And whenever I need to put a patient on more than, say, 2 bottles, and invariably I know that the patient will have systemic comorbids, having multiple medications and so on, remembering to put so many bottles, I think it's definitely a better option to offer surgery to the patient as far as possible, unless there's some very serious risks involved as far as surgery is concerned. I think surgery should be considered earlier in the disease rather than wait for 3, 4, 5 bottles, and now we even have a 6th bottle. So don't keep on maximizing the treatment. So you're going to definitely go in for non-adherence, and patients would not like to use multiple bottles at a huge cost. So definitely go in for earlier surgery when the need for more than 2 medication arises.
It has been our experience that, once we have this armamentarium of drugs with us, it's very common to have conjunctival changes accumulating, and now our surgical results are definitely less than what it used to be about 15 to 20 years ago. So when you are faced with a patient with conjunctival changes, what do? Do you switch the drugs, or especially in preparation for surgery? Dr. Rajul, could you comment?
So what I do if the conjunctiva has severe hyperemia, I like to stop the medication at least a week before. I make you a mild steroid and cover with the systemic acetazolamide for a week. I think that gives a good result, because switching the molecule, if the patient is already on maximum medical therapy, switching doesn't work, because you already have everything. If we change from one brand to another brand, it's not going to make any difference. It's better this stop as far as all the medication possible. Give a short course of acetazolamide. A steroid helps because it reduces the hyperemia for a week, very low dose, low strength steroid, and then I would push for surgery.
So any other variations the others have? If you start steroids, would you check the intraocular pressure after starting steroids for a few days in case there is a response?
Dr. Shanta, I start a week before. The most of the times response happens after a few weeks, and we already have counseled the patient for surgery. So if the pressure is going to increase from 20 to 30, it's not going to spike usually, because the spike usually happens after at least 2 to 3 weeks. So usually that is not the case. So I don't check the pressure.
Maybe Dr. Harsha can answer this. Do you consider the preservative being used for a medication before you decide to prescribe, especially on a patient who's going to be on long-term treatment? When you look at, we have so many of the PG analogs available to us now. So is the preservative factor to take into account?
Yes, I think more and more of younger people being diagnosed with glaucoma, and also in region, especially where I see patients with a lot of these IT professionals with increased screen time who are already prone or having surface problems, I definitely prefer starting them on preservative-free prostaglandin analogs. So I think that will become more popular with time.
Now, do you prescribe preservative-free, or do you use medication with less concentration of BAC?
So both of them I would prefer equally, but preservative-free I probably would reserve for those who show some surface problems even with non-BAC preserved medications.
I think some of the issues that patients describe to us is that they find it difficult to use the preservative-free minims, that it requires a lot of pressure to actually apply the medication. Is that true for all of you, or?
I think the old Novelio bottles which are available, you require to squeeze a lot, but the newer bottles are much easier to use. That is that Novelio the bottles they have changed recently. I think last year. So the newer bottles are much easier for patient to use. They don't have to exert too much of pressure. Second, just to point out, I totally I would like preservative free in all the patients. But the problem is that only one molecule preservative free, absolutely preservative free is available in India. So when you have to add the medication, then the advantage of preservative free is gone. So there are lots of preservative free available outside India, and I hope that they will launch in India soon, where we can go completely preservative free.
Yeah, exactly. I also believe that it is not truly preservative free unless it is unims. And
Absolutely.
all the Novelia bottles and whatever, I don't know whether they've used it or not, but if you squeeze it, you have a lot of wastage. The first drop comes after a long time, and the second drop follows immediately after. So actually, there is wastage that I have seen, and so I'm not very keen on giving those to elderly patients. Definitely not.
Can I ask a question here? I mean,
Sure.
it's probably not related to what you all are talking, but we get two subset of patients as far as the cornea and external disease is concerned. One is the post-LASIK patients who are steroid responders, and other is the vernal catarrh patients who keep, putting steroids and they have glaucoma. So, would you suggest that we could use prostaglandins in these two subset of patients, or would you rather we use a beta blocker for these two subset of patients?
Any of the panelists?
A preservative-free one is definitely, something that you could try. But please remember that the true preservative-free is, is not that cost-effective. For a pack, for a month's pack, you spend about 900 rupees, whereas a Novelia bottle so-called preservative-free bottles comes in about 400, 500 rupees. So it also depends on the cost factor for quite a few. But in post-LASIK eyes, unless they actually have symptoms, why would you
What actually happens is that post LASIK we give topical steroids, and it is then
IOP
that
spike.
we detect, that they are steroid.
No, that I agree. I'm
So, but
saying if they don't have surface changes already and they don't have symptoms, then you can, you can wait till you actually.
So what anti-glaucoma do you give in those
So
cases?
we can give. I think what Vanita she wanted to ask Dr. Madam was asking that whether we can give the PGA or whether any other molecule.
Or we
So
give the beta blocker, or what do you give in?
so
I
I
think
think
she's talking about
depending
steroid-induced
upon the
glaucoma.
IOP, depending upon how much the IOP is, if the pressure spikes is nominal and you require 15-20% IOP reduction, beta blocker would be fine. If the IOP spike is severe and you require 35-40%, then prostaglandin you can give in allergic conjunctivitis and post LASIK because they don't have any intraocular inflammation. The inflammation is outside, so I think prostaglandin is acceptable. But depending upon the IOP spike, how much IOP pressure you want to reduce.
Okay.
I think essentially, I think Professor Namrata is talking about steroid and steroid responsiveness and steroid-induced glaucoma
Yes.
and initial spikes. So I think just stopping the steroid or changing to a safer steroid or trying to reduce the steroid will make a difference initially. And then, of course, I think you can step up by starting with timolol first, which is really well tolerated. And if you want, like Rajul pointed out, about 20-25% drop in the IOP. You don't have to be very, very aggressive in lowering the IOP unless the IOP is very, very high.
But
Most of these will
sometimes
go down.
Sometimes they have such a severe spike of 50, 55.
Correct. Yeah, they have 50 and 60, then the issue is different. But
Then
most
maybe
often
we have to give, maybe they would require acetazolamide also.
Correct.
For short term.
That's true. So depending on the severe,
sorry.
Depending on the severity of the IOP response and the spike, I think you can think about topical timolol. You can also consider prostaglandin and add on oral acetazolamide. But in general, there is no real glaucoma here in that sense. The steroid has been patient has been responsive to the steroid. And we do have some time by stopping the steroid, and then we can sort of evaluate the patient without therapy.
Yeah. So post-LASIK eyes mostly are obviously younger patients. And if it is not just, if you are requiring any anti-glaucoma medication long term, then I would be a little bit careful with beta blockers as well. They are young patients, and it is known to cause decrease in libido and is unlikely to be reported to the doctor. That is also an issue. So not just a problem with older individuals, beta blocker, but also with the very young ones who are active, sexually. This is the time to be active.
This is a question which is often asked because now we have so many classes of prostaglandin analogs. Are they all equally effective? Is Dr. Vanitha, your experience with tafloprost, would you say is as good as any of the other agents?
Yes, absolutely. I would say I am getting, as I showed you, I am getting, of course, I've not talked about add-on therapies because that, there are confounding factors for that. That is why I specifically chose treatment naive eyes to present as well as the switch eyes, because it showed that not only was I getting an initial reduction of 30 plus percentage, but also in switch-on therapies, mostly from other prostaglandin analogs or fixed drug combinations of a beta blocker with either CAI or alpha adrenergic. Yes, definitely, it is making a difference. Another 20% drop, which is is huge.
So another question which comes up is when we all know that target intraocular pressure has been talked about extensively, and the AGIS results pointing to trying to achieve a IOP of 12 millimeters would really stabilize glaucoma. I think this has resulted in a lot of practitioners prescribing 2 bottles, each being a combination therapy. So the patient ends up with 4 medications, which they use over a long period of time, ultimately ending up with conjunctival changes. So is that a practice you would advocate, this intensive trying to reach a low target, regardless of what stage of glaucoma the patient has? Dr. Namrata? I'm sorry, Dr. Vanitha?
Yeah. See, the treatment in glaucoma has to be individualized, and it depends on so many factors. It depends on what the baseline untreated pressure was. It depends on what visual field defect the patient has brought in. It depends on other risk factors, like family history, what other medications patient is on. So there are so many things that one has to consider. I would strongly recommend, unless the pressure is in the 40s or 50s, to start with one medication, and that one medication would be a prostaglandin analog to check its response, initial response. If you give combinations, you don't know which one is working and which one is not. And so the first should definitely be a prostaglandin analog, and if required, you can add on. Always remembering that unless you achieve at least a 20% reduction, that drug is probably ineffective. So you need to achieve at least a 20% reduction before you actually think about changing the drug or adding on. So if it is less than 20%, definitely change the drug. I would, given one prostaglandin analog, I would change intraclass as well, because non-responders are also a known phenomenon within prostaglandin analogs as well. So I would first give prostaglandin analogs a chance, and if it's still not working, then of course I will add on.
So it's definitely a must that you start off with a single drug and then.
Yes. So unless pressure is extremely high, where we don't expect it to come down with one drug.
See, I just want to add, Dr. Shanta, when you said, this less than 12 thing, stabilizes glaucoma, I think it came after AGIS.
Yeah, that's right.
And the AGIS, they actually manipulated the data because the visual field score was 0 to 20, and initial definition was the change of score of more than 4 would define progression. But subsequently, when they came up with this less than 12, less than 14, this graph, the y-axis had only 0 to 4 or 0 to 5. This was a gross over-exaggeration of the 1 millimeter IOP reduction in less than 12. If you expand 0 to 20, 0 to 20 score on y-axis, the difference between less than 12, less than 14, less than 18 become very small. So I'm not saying, of course, IOP reduction is important, but the age is just to, they extrapolated the data beyond to actual the limit. So that is, I think people should realize that, that laser and tear in every patient is not required. You have to set the target patient, as Dr. Vanita said, you follow that, and sometimes you may have to change that because it's a dynamic phenomena. Sometimes if the patient progresses, you change, you may have to become more aggressive. Sometimes if patient remains stabilizes, you can actually go and do a reverse trial also. So those things you have to keep changing it depending upon how the patient is, you are following up the patient and what you think about the individual patient.
Another question which is asked quite often by general ophthalmologists is, what is the cutoff for treatment of ocular hypertension? Is there an intraocular pressure cutoff? So, Dr. Harsha, would you comment on this, taking our lessons learned from the OHDS?
So generally, the level is something which has to be comfortable to the doctor as well as the patient, depending on how much the patient understands. So anything between 24, anything up to 24, 25 millimeters of mercury with absolutely healthy discs, considering the rest of the risk factors are very, very minimal. You have slightly thicker corneas, no family history. Anything up to 24 millimeters of mercury is something which is comfortable to be followed without any anti-glaucoma medications. Having said that, the other concern for us, if the pressure is over this level, is the possibility of vein occlusions in the eye. So if the pressure is close to 30 millimeters of mercury, for that matter, yeah, if everything else is okay, risk factor wise, then I would consider medication to bring it to a lower level for the concern of vein occlusions. Over 24 to 25 millimeters of mercury, once again, it's a discussion with the patient, consideration of the other risk factors, and then the decision of starting a medication is made.
I think we have almost completed the time allotted. Dr. Bhushan, would you like us to continue for a while? I don't find any other questions from the audience.
The YouTube, there are a few questions, I think very quick ones. What should be the drug to start in cases of normotensive glaucoma? I think that has been already answered. How many minutes should you instruct the patient to wait to close the eyes after drug installation?
I always say 2 minutes.
Okay.
What is more important is one should not be blinking rapidly, because that is what then causes drug overflow onto your cheek. And with prostaglandin analogs, of course, you have this problem of pigmentation and so on and so forth. And on the other hand, it also then drains out through your tears into the nose, nasal mucosa.
And second, you can ask patient to close the nasal punctum.
Should the vials be changed every month as instructed by company in the carton and the label of the vial for optimal and continuous efficacy?
I think we... Go ahead.
Yeah, that's a very interesting question. Actually, with I think most often, I think I instruct most of my patients to continue using the drop till the bottle gets over. But actually, it does work even beyond a month, and for all these are expensive relatively for the patient. I think there's no need to stop the medication at the 30th day. But on I think as far as the drug regulator and the guidelines, as far as printed guidelines are concerned, it's about a month. But I think we can allow the patients to continue the drug beyond 30 days and use it till the bottle gets exhausted.
Well, it's not just the
efficacy. I don't, Murli, we didn't publish anything, but when we was in Vellore, in the first time the prostaglandin came, we wanted to see what happens over a period of one patient using only in one eye. And after 6 weeks, the IOP lowering ability had, in majority of the patient, reduced drastically. And you change the bottle and give the new bottle, again it achieves the same what happens. So I personally would now tell my patients that you can go and use 5-7 days more, but beyond 40 days though of course we cannot write because it's against the regulation, but up to 40 days I usually say that you can use the glaucoma molecules, the lubrication and everything. I ask them to use till the bottle is over.
I think there are some issues with the generic versions of the drugs. I think the generics probably has some issues as far as quality is concerned. But most of our MNC brands, I think 30-40 days is definitely safe and definitely cost effective for the patient. And I have not observed any loss of efficacy when the patient continues beyond 30 days.
No, but the concern is not just efficacy. is also about the shelf life, given the preservative ineffectiveness. Yes, so one is probably, if you tell them 6 weeks, they will probably pull it to 8 weeks.
No, don't tell them 6 weeks. Tell them till the bottle lasts.
No, but if they're using it only in one eye, only in one eye, then it lasts
can go
forever.
on for 2 months also.
Yeah.
Correct.
So
all of us who own our own pharmacies, I think, would love to tell the patient to stop using it in a month's time. People who have their own pharmacies and have other interests. But I think in the general interest of the patient, I think it's probably we can compromise by saying maybe 30 to 40 days is a good compromise.
Yeah. 1 week,
one week extra.
Yeah.
But most of the time when the patient is using 2 times or 3 times, and those bottles never going
get
to last.
over. Yeah.
Correct.
Even with PG analogs, most of them finish a bottle by a month's time.
Yeah,
most of the time they put more than 1 drop anyway.
That's right. So I think we're over time now. So I'd like to thank Santon for having given us this opportunity, and AIOC for have given us platform for this discussion. It has been very interesting. I hope it has been useful to our audience. Thank you all for coming on a Sunday and contributing your knowledge to the public. Thank you once again.
Thank you.
Thank you very much. Thank you.
Thank you, Dr. Amrita. Thanks, Rajesh.
I'd like to give a vote of thanks, formal one, in the end.
Yeah, actually, it was a nice
Very educational
webinar.
for us also.
Yeah. And so I would like to thank everyone, all the speakers, and of course, moderator Shanta ma'am was
perfect.
Yeah. So, I mean, words will be less to thank her. So, thanks a lot to, everyone, to our admin team, Sunil, of course, Kirpal Rana, who is working really hard and, for every webinar. And of course, Santen for, having this webinar done. So thank you very much. Thanks to all. And thanks to, I'd also like to thank, many times we don't do it, but I would like to thank Dr. Namrata Sharma, who is really very active as an AIOS secretary. So
Thank you.
Thanks to you.
Thank you, Rajesh. We would like to thank all our delegates who are watching us on Facebook, YouTube, as well as on the Zoom. We've had one of the highest attendances today. I just wanted to, bring it to your attention on the YouTube as well as on the Facebook. And that is because of the wonderful contribution by all the
That's what I told, that, people, even the general practitioners, everybody wants to learn more and more glaucoma because they feel that they can do something for glaucoma patients. And that is something that drives them to the glaucoma webinar. And when this is so interactive and so good, then definitely people will get glued only, will not leave the webinar. So thanks to all.
Thank you, ma'am. It was a perfect
Thank
webinar.
you.
Thank you so much. Thank you all.
Thank you.
Thank you, everybody.